Let me start by saying that the risk of cancer associated with AAV vector dosing seems low, and currently it's only theoretical because so far we have only seen it in preclinical studies in very young rodents or grown-up rodents with damaged livers. And we haven't seen evidence in large animal models or in the clinic that AAV vectors could trigger malignancy. On the other hand, we do have evidence from both preclinical and clinical studies that AAV vectors integrate in the genome, despite the relatively low frequency of integration. Most of the administered AAV vectors settle in the nucleus as episomes, but some integrate. And it is important to appreciate that the vector integration itself is another rare event, and that is because gene therapy administration involves infusion of trillions to quadrillions of vector particles. So there may be millions of integration events, even at low frequencies of integration reported between 0.01 to 1%. So that means that every vector recipient will have vector integrations. The question is whether they can trigger oncogenesis. So again, we don't have evidence that AAV integration can do that in humans, but we do know that integration of retroviral vectors may trigger malignant transformation in humans. So these two observations warrant malignancy surveillance and careful integration analysis when cancer occurs in vector recipients to evaluate whether the cancer could have been associated with gene therapy. This is, of course, easier said than done because there is no standard procedure or universal guidelines delineating the course of action upon cancer diagnosis. But we have some real-world clinical experience already that provided important learnings. One important point to make here is that systemically delivered AAV vectors go everywhere despite tissue tropism. They go primarily to the liver, and liver-specific promoters will largely limit transgene expression to hepatocytes. But other tissues will also get transduced. So malignancy surveillance should not be limited to the liver. When cancer occurs in a recipient of AAV gene therapy, the first step really is to contact the manufacturer, ideally before doing anything else if possible. Approved products list contact information specifically for reporting malignancies. The manufacturer will provide instructions on collecting patient samples for integration analysis. And that first phone call will be quite critical because sample collection will determine the feasibility of robust integration analysis. There are several histopathological requirements that will need to be met depending on what kind of analysis the manufacturer will be carrying out. Individual methodologies may require minimum tissue quantity and purity. There may be restrictions related to the tissue preservation medium. There may be specific preferences for sample format, healthy comparison tissue, and timing of sample collection, for example, in relation to the cancer treatments. So this first step will really be crucial, and it will necessitate good coordination and communication between the reporting physician, the manufacturer, and the pathologist involved in sample collection to ensure that the sample meets the requirements. And of course, the extent to which this will be able to be prioritized will depend on individual circumstances, and the patient's well-being will obviously come first in those determinations. PCR-based methods generally have minimum histopathology requirements, and they offer a fast turnaround, but they do not measure integrations, really. They only measure vector genome levels, which is good enough to compare the amount of vector in the tumor versus the surrounding tissue, but otherwise limited in terms of making any judgments about causality between vector integration and malignancy. Next generation sequencing methods provide more information, but they have more stringent tumor sample quality requirements. They require large amounts of DNA to carry out analyses, but they can actually identify integrations. They can determine frequencies and locations of integrations. So these methods are very informative, but they take time. They take months to complete, and they involve large bioinformatic workload, which requires specialized expertise to execute. There are several next-generation sequencing methodologies now available. These methodologies keep evolving and offer additional advantages. For example, whole genome sequencing can identify somatic driver mutations and integration in a single method, which may help understand vector integration causality or lack thereof. But it has the most strict sample quality requirements, and it may be less sensitive than alternative methods. So currently, the most robust analyses published to date used a comprehensive approach combining several PCR-based and next-generation sequencing methods that complemented each other. Having said that, there is currently no gold standard for vector integration analysis for the time being, but it's a very active field of research, which hopefully will be offering a better understanding of the risk we are trying to assess here moving forward.